and finished her training, and she has been in practice on the Upper East Side in New York City for how long?
7 years now.
Okay,
On my
okay.
practice.
Okay, so she has a practice where she focuses only on weight management and endocrinology, but we're gonna get more into it because it's much more complicated than that. And one of the things that I love most about you is your holistic approach to human beings. This as a human condition, and that's very close to my heart because that is also the way I practice. So I wrote down a million questions and we will go through them, and we will also make sure that we have time for your questions and for your questions. And yes, you're gonna keep me on the clock.
Yeah.
Right? Okay.
I got you.
Because otherwise we may be here all day. Some of you may enjoy that and some of you may not enjoy that. Oh, because that's here so we can start. Okay, good. Okay. So the first thing tell us a little bit about you. Tell us about you. You're not only a very, very exquisitely trained physician, but you're really, one of the things that I love about you online is that you as a human being really shine through, and your advocacy really shines through. So I want to hear a little bit more about you.
Well, I think that comes from my father, my dad back home. He taught me empathy like very early on by his actions, not saying it to me.
Yeah.
Like he would always like extend help anybody at any time. And he made me think of how other people could be feeling at that moment. Like put yourself in those shoes, right? Like what it could be you. Like and that I think that really made the person that I am. And medicine is talking with the patient, right? It's like you are talking to a human being, you are talking to somebody's mother, to somebody's brother, to somebody's child. And I think as doctors sometimes, because we're focused on your numbers, on your health, that we forget about the whole person as it is. So I think it's very important that we remember that we're treating human beings, right? And I always envisioned me as a doctor that had relationships with patients. Like I wanted to be that doctor like for 10, 20 years, that I was part of their lives and then part of my life. And I think that's what I've worked towards. And even though I didn't open my practice immediately after training, I feel like all the other jobs that I took really show me what is it that I would take from that, or what would I do differently. And so I do think it's important to have that experience. I worked as a medical assistant for 3 years. So being a doctor when I was studying for my boards, and I think being an employee also helped me a lot. I think you cannot be a good boss if you never were an employee, right? So I think all my life exposure and experiences have really molded the practice that I have and who I am as a person, right?
Yeah. Were there any people in medicine in your family? Like, what do you think led you to medicine? Because I know you've said that you, from a very early age, knew this was your path, this is what you wanted.
In fact, my older brother is the only person that has gone to university from my both extended large Mexican families, and I'm the second one. So there were no doctors in my family, immediate or extended family. I'm still keep being the only one. Although my 5-year-old nephew says he's gonna be a doctor. So I'm like, finally somebody might practice it, because my kid said no. But it was just like the right to help. That knowing that I could make a difference in somebody's life. And I was very inquisitive, like why and how does this work? Like I always wanted to do that. How does TV work? How does the radio work? Like how does the body work? Like how does medicine work? What happens? Why the antibiotic? What does it do that goes into your body and helps you? Like I wanted to know.
Yeah.
That.
So you were that kid that was taking things apart, or at least thinking about it.
Yeah, thinking about it.
Yeah. Okay, that's a perfect. I mean, in my opinion, that's the perfect combo. Like having that sort of scientific inquisitiveness with the empathy, and that's obviously what we like. That's kind of the
detective part, right?
Yes,
like you have to ask questions, you have to get details, you have to what happened, the time, the date, and this. And I think also as doctors we forget to ask. And I had a teacher in Mexico in my school of medicine that he said, if you ask enough questions, the patient will give you the answer always. So I feel like the more you talk to the patient and the more you figure it out and the more like you like, oh, okay, this is what happened. Versus just not talking to you, looking at your number, ordering you the study and then, but not talking. I always tell the medical students, talk to the patient, you ask the patient.
Yeah.
So it's-
Well, and that's a systems issue too, right? Because you and I are both fortunate enough now at this point to have the time. But, you know, even if you're curious and you don't have the time, you gotta roll the patient through. And what's the data? Something like it takes how many seconds until the clinician interrupts the patient with an encounter, like it's very, like 10 seconds, it's something like very, very short amount of time. So, all right, I mean, was there something? What motivated you to write this book? Like, was there a moment, an event? Was it an accumulation? Like, what made you say, I have to write this book?
So I think if there's three reasons I've thought about that, like through my journey with the book. I think the first time that like look, it clicked me that oh, I have to write this is very early on when I opened my practice and I was having patient after patient coming to tell me I've been exercising, I've been doing diets, since I'm 30 years old, I've been to a fat camp, I've read all the books. Like I couldn't like I was shocked to learn that everything that we thought was not true.
Say more
By
about
talking
that.
to my patients,
Yeah,
right?
yeah.
And that's the importance of talking. And that's, I mean, I know having a private practice seems like, oh, you're not giving care for everybody, and that's another reason that I wrote my book. But that's the place that you have the time for the patient to let the patient talk, hear the patient, and then you learn more. So that was the time that I said, okay, people need to know this, that patients were actually doing everything and more
Yeah.
of what we were recommending.
Right, it wasn't working.
And it wasn't working. And then that idea that we had of the patient that they're not listening to me, they're not telling me the truth, really, they're not working out. If I go to their house, I would see the food that they're eating. Like we always attribute to the patient being non-compliant, being lazy, or not smart enough, or not wanting to lose. That idea, like, oh, if they wanted to lose weight, they would have lost weight. I haven't met a single patient that has obesity that wants to have obesity. Right? They're the most invested in their health.
Yeah.
And I feel like that was the moment that I said, okay, everybody needs to learn this and know this, right? So we can see patients with obesity as humans and not as a problem. So that was the first time. And then the second time was when I realized that I'm one person. I cannot, even if I charge for free, I couldn't see everybody, right? I mean, I'm my own limit as a human. So I felt like this is my way to give all the information that I've learned without necessarily being a patient, right? That's like a gift for everybody to have. And it's like everything that is here, I put it there, right? I don't remember the third reason. Those are the most important ones. So,
But I have to tell you because, so, you know, I've been listening to this on audiobook all week, and I have a lot of really smart friends and colleagues. And no, I mean, no shade to any of them because their books are amazing too. But this book is, I'm so excited for you all to read this book because it is such a detailed explanation of everything from the history of the science to the actual science of how this works to what you can actionable items that people can do on their own. I mean, it's really practical information and it's really amazing. And it really, I mean, I was telling, you know, it really moved me personally too, because I wanna stop for a moment and talk about the word obesity, because we use it in medicine. There's a lot of words we use in medicine and we know what we're talking about. And they are medical terms and they do not have judgments in them, but they gain a lot of judgments outside and characterizations, and the word is really triggering.
yeah.
So maybe we can just step back for a moment and translate that term so that people understand what it means for us, and when we use the term, what does it mean? Because you talk a lot about weight management, weight gain, and obesity in the book as a chronic condition. I want you to really unpack that a little bit for us.
I mean, this is something new that for the majority of people that they're hearing for the first time, right, obesity is actually a chronic disease itself, not necessarily a risk factor for a chronic disease. Itself it's
right. In other words, so like, because we know that being over, well, I mean, we could talk about BMI in a moment, but being over a certain amount, we're going to increase our risk for everything from diabetes to hypertension to cancer to heart
but
disease.
like down the road.
Right,
down the
but
road.
in and of itself, that being over a certain amount of weight and actually more specifically, you'll talk about that, is itself a condition.
Exactly.
Yeah.
So if the definition of obesity is chronic, meaning not necessarily curable, that is long term, multifactorial, that there's not only one cause of obesity, meaning it's not just willpower for and not having willpower. And it's a multifactorial chronic disease, right? So it's a disease in itself, it's not a risk factor for other diseases. So I always try to, and I think that's what the importance of body composition is, because when we as doctors, we wanna decrease your risk of disease and increase anything that can improve your health. That's
Right.
basically what we
Right.
wanna do as doctors, right? And when you think about obesity, it's the same thing. Like, I wanna reduce the risk of what's going to make you sick, and that's excess body fat, or visceral fat. So it's decreasing what makes you sick, and then talking about muscle mass, because that's going to be health, right? That's going to improve and reduce your risk of disease. So that's when we think about obesity, at least I do, that's what I see, right? Like, I have to reduce your risk of disease by reducing your visceral fat, the excess body fat, and improve your risk of health, or improve your chances of being healthy by improving muscle mass.
Right.
So that's what we have to think about when we think about obesity. And that idea, I think of like, oh yeah, you're gonna develop diabetes in 20 years. If you don't do something about it now, you're gonna develop hypertension, high cholesterol, right? It was always like in the future, it's a region like I don't care. I'm good now, I feel okay now. But what did COVID came and taught us? And I think COVID was like a really eye-opening for us as physicians and for people too, because came a virus out of nowhere, nobody was expecting it. And who are the people that had higher mortality, higher ICU or intensive care unit stays, or more long-term complications? It was people with obesity. So COVID showed us that we didn't have to wait for you to develop disease. Having obesity, it puts you at risk at any moment, not only in 20 years. Why? Inflammation, right?
Yeah.
Visceral fat, the internal fat, is active. It's not dead tissue just hanging there. It actually produces cytokines, chemicals that keeps your body in chronic inflammation. So your immune system that is built to protect you from any virus coming in, bacteria, cancer cells multiplying, they're occupied with the visceral fat causing inflammation. So it leaves the door open for anything to come in, and that is COVID, right? So obesity, even if you don't have symptoms, right? That idea of like healthy person with obesity, even though you don't have symptoms, your body is in inflammation. And that means that your immune system is not doing what it's supposed to do. And that's when the door open for virus, bacteria, cancer cells, right? There's more than 13 types of cancers associated with obesity, increasing the risk, breast, colon, prostate, thyroid, pancreas. So all of this, why? Because your immune system is preoccupied fighting the visceral fat.
This is such an important foundational concept, and to me, it really is a demonstration of your sort of holistic, your unique approach to this, and the holistic way in which you are thinking about it. This is really profound and paradigm shifting in many ways. I want to really stop and like recognize that, and I want to make sure you all are getting that, because I think, you know, we, especially women, and not everybody in this room is a woman, and I'm not saying that men are not subject to body image issues and body dysmorphia and all that, because it is rampant. But I was raised here in Los Angeles in a time where I'm squarely Gen X, you know, and how you looked and the number on the scale was what it was all about, right? And it's like, that just upends that whole thing. Because when you really understand that your body composition is setting you up for health or disease, not just in the future, But right now,
Mhm.
that's like a whole other
Yeah.
way to look at it, right? Yeah. And I thought that you're making that connection with COVID was really interesting too.
Because I saw it in my practice, I have patients coming to me and telling me, I need to lose weight, I don't wanna die from COVID.
Mm-hmm.
So
Mm-hmm.
the message was starting to be received, and then we had the treatment.
Right.
So the demand started to increase,
Yeah.
and we had the treatment, so it was just like the perfect combination,
So,
right?
So
That's where
talk
we are
about
right
that,
now.
because I think a lot of people have this idea that like all of a sudden Hollywood celebrities just decided there's a new easy way to be skinny. And poof, this medicine showed up, and that is actually not even close to the case.
Yeah, and I think that's one, as a society, and I'm not saying individually, I think that's, and I see it in my kids that they're 11, I think that that preconception of fitness, skinny equaling healthy or more smart or more active, you know what you're doing, it's really ingrained in our genes.
Yeah.
Right, I
Yeah.
think my 11-year-old, and even though I do what I do, I wrote a book, like, she still thinks like that, right? And I'm like, and I don't have that conversations in that way at home. It's all about healthy and muscle and all of that, but it's in schools and the TVs, right? So we associate thinness with something aesthetic.
Yeah.
And that's the problem, because when we associate losing weight with something aesthetic, that's why there's rejection of the medication, because they're gonna say, why are you going to inject yourself just to lose a certain way? Are you crazy? Why are you putting chemicals, right?
Mhm.
But when you see it as what I just discussed, as a health problem that we have a solution at the moment, then it's the acceptance comes in,
Mhm.
right? When you see it internally. So I think we need to stop moving away from that idea that thinness equals health, equals better, equals smarter. And I see it, and I see people that are thin, they actually think that they're better than somebody with obesity because they're skinny.
Yeah.
And that, I mean, that to me is like, that's another reason that I wanna hit them with my book in the head. I think that works like going there. Because it's so deeply ingrained in society,
Yeah.
and the celebrities and all of that just adds more to it, right?
Right.
Because they're not talking about, oh, now I can bend and tie my shoes, right? They're not saying, oh, now I sleep better. They're not saying my joints don't hurt anymore.
Mhm.
They're not, right? You just see them and appearing, and they're happy, and they're,
Well, I think especially in the beginning, like all of a sudden you'd see somebody and be like, whoa, what happened? I feel like maybe there's a little more openness about it now, and I think reframing the conversation as a health conversation is really a golden opportunity. But I mean, that's like a whole, I mean, it's tangential and not, I think it's central to the way we think about ourselves, we think about our health. And even I see people all the time, because I have a body composition scale, and that's literally the first thing I do with my patients in the office. And a lot of them are really surprised because they're at their goal weight. I'm gonna ask you a question about that. And they're close fit, and then they're like, they see how low their muscle mass is, and they see that their visceral fat is high.
yeah.
And they're like, whoa,
I
you know,
think, yeah.
they're very surprised, and that happens relatively frequently.
Yeah, I think for the change to happen, first, we have to accept that obesity is a disease.
Yeah.
Because if we don't accept that, if we don't understand that, if we don't take it as a truth, then it's very hard to get over the hump of using a medication for weight loss.
Yeah.
Right, but if somebody has type 2 diabetes, we don't say, oh, wow, what are you not doing by yourself? Why are you not trying to lower your sugar on your own, right? Or lower your blood pressure on your own,
Right,
right?
right.
We use medications, and they
Right.
don't have the same bias
Yeah.
as obesity
Yeah.
has, right? But so the first step, we have to move into accepting that obesity is a disease.
Yeah, I mean, that, and I think that's probably just, we just have to be destigmatizing and talking about it.
Yeah. And I mean, that's one reason
Yeah.
that I wrote my book, right? I mean, it just gives you all the explanation that it goes even beyond you are born. Your genes already know if you're going to be predisposed to having obesity, right? It can be inherited.
Yeah, talk about that a little. That's pretty interesting.
And that's really, I mean, when I tell my patients this, I can see like their body language, like the shoulders like get relaxed, right?
Mhm.
Because, and now we're learning more about obesity, right? I think these medications really are driving the force of how much we are learning about the body, about muscle. But we know now, and I posted that today, I don't know if you guys saw it, but even trauma that your grandparents like experience, your mother experienced, right? That can cause changes in your DNA, and that's called epigenetics. So then that can predispose to diseases, including obesity, right? What your parents' weight was pre-conception of you can already like make determine if you're gonna struggle with. So when you tell a patient, it goes even beyond you were born. Right. So
Yeah,
and it becomes so hard because you're fighting that.
yeah,
Right.
right.
We live in a society that really sets us to failure, unfortunately. And I don't want to say like it's doomed because we have things to do and we have options for treatment, but like chemicals, environmental factors, endocrine disrupting chemicals, right? Like what we used to clean the floor, what the painting in our walls. We live in a very industrialized society, including our food being very industrialized, right? So that is one that can cause obesity. We know there in environment there's obesogenic chemicals that promote obesity, right? And then we go aging. Aging also can lead to not necessarily changes in your body composition, low muscle mass, more visceral fat, right? And then we go medications. Some medications that we take can promote obesity, and we don't tell you that. We don't give you the option, right? When we're going to give you a medication for blood pressure, rarely do we say, and this medication can increase your weight. Right? Or psychiatry medications, antidepressants. There's so many medications out there that can promote obesity. So we're adding environment, the food industry, medications, our genes, right? And then this is you. This is the control that you have of what you do, food or exercise. And that's why it becomes to be so restrictive and so difficult to maintain because you're trying to fight all of this, that if you stop it, all of that comes back, right? We're not curing your genes, your hereditability. We're not moving you to a farm where there's no industrialization. I mean, right? The food industry is like hard, like to really get like good quality food. And if we have it, it's not accessible to many, right? So so that's why there's so many factors outside the patient's hand.
Yeah.
That can promote obesity or make it hard for them to lose weight. And when a patient hears that and truly understands that, then they open for treatment.
Yeah, exactly. Because it's not just like a willpower issue or accountability or a character defect or something like that. There's all these other forces at play. And I know that can sound overwhelming. So I don't want people to be like, oh my God, I'm doomed and everybody has to be on drugs. But I mean, but I think I do think for people who have really struggled for a long time, at least the onus of responsibility is not like, it's not like they're a failure, because that stigma, they're also adopting the stance that is very self-loathing.
Yeah.
There's a lot of shame, like I've failed. If I would just do this one thing right.
And I think another very important thing that we like to have control on the things that we do, right? We like to have control, some sort of control. So if you tell somebody this is a medication that's going to do everything for you, it's also a little bit, it's hard to accept that you're going to lose all control and you're not going to do anything, but actually that's not true.
Right.
I still need you.
Yeah. So I want to get into that. I want to get into
right?
that.
So,
because that's the other thing I think about your protocol. It's not really a protocol, but the way you view this, the way you manage it is again in a very holistic manner. Because the other side of this is that, as a physician, I know that there's also, sometimes you guys just want us to wave the magic wand and now you're better. So here's your GLP-1, bye. Now everything's great. And it's like, that's 100% not how it works.
Yeah, and actually, I rarely see that. I think patients, it's just that communication, right? That connection, that relationship that you build with your doctor and that we build with the patients really sets the way that the journey is going to go, right?
Yeah.
But when something beautiful happens when you remove the pressure of weight loss in exercise. It's like, and I see it on my patients' faces, right? Because when they come in and they're really like into it and they said, and I explain everything and they're like, okay, should I be exercising? And I tell them, yes, but not to increase the weight loss that you're going to have with the patient.
So
Right?
talk
Because
about
they're
that.
starting, okay, if I exercise, I'm gonna lose more faster, right? And they're like, what? Like, that's such a out of space idea of exercising, but not for weight loss. When you remove that stress, it becomes something that they actually want to do.
Yeah.
Right? They don't have that pressure. Like, if I don't exercise, I'm not going to lose weight. If I'm not 2 hours on the treadmill, when you tell them, okay, you go 40 minutes and lift weights.
Right.
It's like, oh, it's different, right?
Yeah.
It's different. So they become more interested in the participation because that's the part of the control that they have, right? You have control. I need you to, I give homework to my patients, right? Like, you need to increase your protein in your diet. This is how you have to do it. This is are the portions that you're going to have in a total. This is the exercise that you need to do. So, and then together, then that's where we have like the result that we have. But we are very visual too. So it's very different that, like you say, oh, you want to lose muscle. When you see it, is when it really clicks for many patients.
And you mean with the body
With the body composition, right?
Yeah.
When they come in and you lost 20 pounds and they, okay, but you lost 6 of muscle. It's like, oh, then they get it too, right? So it doesn't happen in the first visit, right?
Right.
Some patients, yeah, immediately are ready for that. Some patients, it takes 2 or 3 appointments to really understand it. And then after that, once patients start feeling strong and not looking necessarily thin,
Yeah.
it's like my work is done. Because you don't want to go back.
Right. So, I mean, it's interesting because, you know, one of my questions to you was, and I feel like this is probably part of the answer, how can we move ourselves out of that like goal weight mindset and into goal health mindset?
That's it.
Because it's really ingrained.
And especially women after 55 years old. It's like I struggle a lot to and even if I show them,
We all have a magic
even if
number.
I
We
show
all
them,
have a
some
magic number,
patients
whether we
say
admit it
no
or not.
I
Yeah.
say, look, but you gain muscle, and it's like, but I don't want to see the scale going up. It's really hard, and I think because it's so deeply rooted in our society and in how we think and how we see women, right? It takes time.
Yeah.
It takes time. And that, I have to say, one patient of mine, she was like 68, 69. And I kept like, it took me almost a year. She had osteoporosis. She could almost took some patients, it takes me that long to work and work and work. So finally she understood. She started gaining muscle. She gained about 3 pounds of muscle. Like, you can gain about a pound per month if you have the discipline. And she came to me and she said to me, doctor, I was going to fall and I felt my core help me stay. It prevented the fall.
Wow. I mean, thank God she prevented the fall, right? And didn't fall and break her head.
But why?
Yeah.
Because she felt the core.
Exactly.
It held her.
So
Right?
you needed to have that much of a like actual experience.
But that's how that's how it's not just how you look. I don't want you to look like Arnold Schwarzenegger. Like, no.
Unless you want to. Listen, do you?
Yeah. But it's just like, it's in the day-to-day things, right? I mean, and when patients feel their body helping them, it's very different than what you look in the mirror, right? I always say it's like the cherry on top. How you're going to look is the cherry on top.
Right.
But how you're going to feel is going to be very different.
So let's talk a little bit more about that, because you're very methodical in your approach to that. Can you sort of go through, and you've touched on it a little bit. Obviously, we're aiming for body composition changes. Not everybody's going to have access to, you know, a very expensive DEXA or even what kind of, you know, body composition skills you and I have. So we can sort of talk about that too. But what does the change in our food look like? What does the change in our movement and strength training and resistance training look like? What does the change in our stress and sleep look like? What are the things that you really recommend that people can adopt today, this week, whether or not they have access to a doctor like you?
My book.
It's all in the book.
But
and you all have it, so that's great.
I think that we need to be smart, right? We need to be proactive about our health, and I think we all need a body composition. Because your body composition will tell you more than your labs, than your blood work. It's just like when I see a body composition, I know if the patient is sleeping, I know what the patient is eating, like, because you need to know. There's no more like, oh, I don't know, you know, then we need to know, right?
Mhm.
One thing is you receive the information and then you act on it. Another thing is just read it and then the book there, right? So I think we need to be more responsible and really do a body composition. And you don't need to buy a 30,000 in-body machine, right? That's like, those are the professional levels you can buy in Amazon. And they tell me, well, is it good enough? I always say it's better than a scale.
Yeah.
It's going to be better than a scale because at least it gives you some idea. You can also go to inbody.com, and I'm not sponsored by them. But if you put your zip code, it shows you gyms, offices that they do.
Yeah, it's very inexpensive.
It's very inexpensive. And if you're in a gym, sometimes it's free.
Mhm.
But we all should start with a body composition, and that really that's going to guide you on what is that you need to do.
Right, so you kind of know where you are in terms of what your total fat, your visceral fat, and your muscle mass is.
And in general, like, and I give tips in my book, if you don't have body composition, how do you know what's working or not?
Yeah.
So if you're on a GLP-1 medication or any journey for weight loss, if you're losing more than a pound per week, you're losing muscle. You don't need a body composition for that, right?
Mhm.
If you're losing half a pound to 3/4 of a pound, most likely it's exclusively body fat.
Oh,
Or 90% body fat and very small amount.
okay.
So that's a good way to know. Also, if you're targeting 100 grams of protein in women, and this is like what ballpark for the majority of women.
Yeah.
Then you most likely what you're losing is body fat and not
Right,
muscle.
so you're preserving.
So there's ways that you can know at home if you're on a GLP-1, if you don't have a body composition, what's happening with your internal knowledge.
Yeah, that protein, who here feels like protein is their second job? Yeah. It's overwhelming because there's a lot of stuff online about it and it's very overwhelming.
But you know what? It's like, I'm like sitting back and I said, I couldn't tell you this 20 years ago, right? Because protein has always been important.
Yeah.
It's not like the diet du jour. It's not like, oh, today is a protein movement. Like I remember when I started lifting weights almost 30 years ago, I was taking 2 shakes of protein.
Yeah.
Right. So it's not like, oh, this is it really protein is your best, it's the most important macronutrient that we can have. Right. You can lift heavy, you can lift every day, you can lift as heavy as Arnold Schwarzenegger. You're not going to gain muscle if the nutrition is not there.
Yeah.
So that's the other part of the control of my patients, the lifting and then the nutrition.
Yeah.
Right.
Yeah.
And you cannot gain muscle if you're not going to have the nutrition, and you need the nutrition to preserve the muscle. You need the strength training to build muscle, right? But it's not a fad diet right now.
Right.
Of course, the food industry is taking advantage and they're doing protein coffee, protein popcorn. It's like the problem with us as a society is that we go extremes.
Yeah.
Zero protein and then too much.
Well, and then there's
That's
also
so
the
hard to
weird
resist.
stuff in those products.
Yeah, and it's like there's
talk about
processed food, right? The bars and all of that. I mean, but protein is not something that is in vogue right now.
Yeah. It's almost like getting back to the basics.
Yeah, the problem is that we're so used to not eating protein,
Yeah.
and now it looks like a freaking full-time job,
Yeah.
right?
Yeah.
But if you're gonna invest your energy in something, it should be on that.
Yeah, and you have some really, really actionable tips on how to do that.
And easy,
Yeah.
because I never want to give anybody of my patients or anybody something that is going to be hard to be
Yeah.
sustainable.
Yeah.
Nobody wants that, right?
Yeah, it's true. It's so true. And I think when you feel overburdened, then you're just gonna give up. And then it's gonna be kind of a vicious cycle because for anybody who's trying to stay healthy, you've touched on a lot about muscle, but muscle is an enormous metabolic driver. And it's like if you don't preserve and build muscle, and also we have patients who it's not even about preserving muscle, it's about building muscle. To begin with, and maybe they've been really like cardio people.
Yeah.
We love cardio, it's not bad, it's just that it's not gonna necessarily build muscle.
And don't do it to lose weight.
Right.
Do it for the mental health, right? Do it because you want to sweat, do it because you want to music, but not because it's going to make you lose weight.
Yeah.
And muscle, I mean, muscle is an endocrine organ, actually produces hormones. It produces myokines, and these are anti-inflammatory hormones, right? Muscle consumes 80% of the sugar in your blood. 80%. It sucks it up for energy and converts it for energy, right? So if you have low muscle, that's what insulin resistant, hyperglycemia, type 2
Right,
diabetes
now you're
happens,
all,
right? So because your body is overproducing insulin because it's not, there's no muscle there to metabolize the sugar.
super important.
Super important. So really, it's not muscle, it's not just because, oh, it's your most important metabolic organ. Muscle burns fat for energies there. There's muscle that's going to burn fat for energies. Again, consumes sugar. It produces anti-inflammatory hormones, myokines. So the best thing, and that's why I switch my patients for their concentration. I want it to be purely muscle. I'll take the medication and myself, I'm going to take care of the fat. I want you to learn, build, and work on building muscle.
Okay, that's really good. I love that. So it's not about like your job. This burden of losing the weight is not on you.
Give it
So nice. Yeah. Oh, wow. Okay, I have so many more questions. I'm trying to think. Okay, one of my favorite quotes that you said in the book very early on, and it really spoke to me, was that listening is learning. And that changing, being open to lifelong learning as physicians is required, and that you had a change of heart yourself about microdosing. I want to hear.
That's what
I want to hear about that.
Okay, the problem with microdosing is that people are starting to look at it as a supplement. I'm not going to microdose for a week. I'm going to take it as a microdose. I don't really need to lose weight. But it's like you're taking magnesium or I'm taking vitamin D. It's not. It's a prescription drug that needs medical supervision. That's how we prevent those side effects from happening, right?
Yeah.
If we start thinking of microdosing, we're really minimizing this life-saving, life-changing drug to a wellness thing or a supplement thing, right? So that's my first argument. The second argument is that microdosing will be 1,000 of a dose, right? That's my.
Well, the other thing is there is no protocol for microdosing that I know.
All the studies, every medication, they study what's the therapeutic dose, right? What is the dose needed to have the effect that this drug was developed for? And those are usually the doses that we have, including in a GLP-1. Those are the doses where the studies show results that we were wanting, lower glucose and lower body fat, right? Under doses, subtherapeutic doses will most likely not going to have an effect, right? Because it was already studied. They studied the lowest dose and you had to go up and go up where it started seeing effects. So if you need the GLP-1, you need the regular dose, then there's no problem, just use the regular dose. But the problem is when I don't really need to lose weight, so I'm going to do a little dose. Well, my answer to that, and be very vocal about that, if you think that you don't have to lose weight, show me your body composition. Because as you start saying in the beginning, we have the skinny fat or the sarcopenic obesity that you look slim because you don't have muscle mass, but inside your body fat is high. And then you use a GLP-1 and then you start to feel great. And you're like, well, I didn't to lose weight.
But you were probably losing
some visceral fat, right? Or the concept you were eating too much pro-inflammatory food to begin with, that so you needed the regular medication, right? You needed the regular dose. Because if somebody says, I don't really need to lose weight, and I see their body composition, higher muscle mass, low percentage body fat, low visceral fat, I know that they're eating healthy, I know that they're sleeping, I know that they're exercising, I know that I know what their environment is, I know their discipline. Not GLP-1s won't bring anything else, right? Because your muscle is already taking care of that, your low visceral fat is already taking care of that. You're already eating high protein and lean protein diet, otherwise your body fat and your muscle will be high. So if your muscle goes up and your body fat goes up, that's lean protein. Sometimes they eat all type of protein, then body fat and protein goes up. So you can tell a lot from a body composition. So there's no added benefits than having a healthy body composition by using a GLP-1. Very different that you don't know your body composition. You think you don't need to lose weight. Your BMI is 21. You use it and I say, well, I felt the effects. Well, guess what?
Yeah.
You did the
It may-
medication.
yeah.
And you need the regular dose.
Yeah, okay,
What I see, the benefit or lower doses of the standards that we have is for maintenance.
yeah,
It's for maintenance. It's for somebody who lost all the weight on the first dose. And then for maintenance, I may use half of the dose,
Yeah.
a third of the dose for maintenance.
Yeah.
But if a patient went up to 50 milligrams of Mounjaro or Zepbound, most likely they're gonna need 5 milligrams or 2.5 milligrams. But if you lost all the weight at 2.5 or 5, then maybe we can do a lower dose
yeah,
for maintenance purposes, but not to get us there.
okay, yeah. Yeah, okay, that helps. I mean, we could go crazy and do another 2 hours, but I think we're gonna do not that. What we'll do, Yasmin, is are there any questions coming from
Not
the
yet.
people on the webinar? Okay, great. So-
Maybe announce that they can ask questions.
Yeah, so if you guys have questions, put them in the chat. We will manage that, but we have a lot of people here. And I want to open this up to questions to all of you. So let's have at it. Who's got questions?
What do you recommend for body composition? What are you looking for? Sort of an ideal range?
So, I mean, there's three important things that you're gonna get from a body composition.
And let me just repeat it because I don't think people can hear it. So we're just asking about what are the ideal body composition
Markers.
markers? Okay, sorry.
So there's three things that matter in a body composition. Your percentage body fat. Percentage body fat means what percentage of your weight is fat. Pretty easy, right? We want in women, the percentage of body fat to be around or below 28%. So maybe a quarter of your weight should be fat. More than that, no, we don't want that, and that leads to disease. And in men, it's a little bit lower, it's 20%. So in men, 1/5 of their weight should not be more than fat. Right? And in women, I mean, it could go a quarter, right, to be that. So that's the percentage body fat. Visceral fat is your internal body fat that surrounds your organs. Now, what we feel here is what we cannot feel, what's inside your abdomen. That attaches to your liver, gives you fatty liver, pancreas, insulin resistant, right? So that's the visceral fat. And then muscle mass. And the muscle mass is going to be very dependent on the sex, on the age, and the height of the patient, right? So I cannot give like an exact number, but anywhere probably 60 pounds of, I mean, I'm just ballparking, 60 pounds of muscle maybe in women. But again, depends on your height. But so those are the three important markers that we're looking for.
Very helpful. Great question. Do you want to go home or?
No.
I do have a question. Thank you so much for all of this. This is really like powerful, especially with so much changes occurring. I know that one of the things that again, you said there's the body spec, or the body composition, and then you have BMI. And I know that we've kind of gone towards body composition for making a decision. But I guess my question really becomes, so how do you look at guidelines for somebody who is maybe be a candidate for microdosing? Like, is it purely on a body composition? Or let's say they have a certain BMI that may be 25, right? That may not necessarily be what the, criteria is, like 30 is, cut off for obesity. So they don't qualify as obesity, but they, are struggling with this, weight gain. Like, I feel like inflammation has become a reason, to prescribe GLP-1.
It's not
That
Motrin.
some people say.
It's not Motrin.
Right. So this is where I'm like, can you maybe just kind of outline for some of us clinicians who started prescribing, but have gone from like what certain guidelines are to now looking at, okay, so inflammation in the body.
No, so this
What is-
medication, yeah, so
What
that's
is, what is
decreasing.
acceptable?
Yeah, I mean, your best anti-inflammatory organ is muscle, right? So if you want to work on inflammation, work on building muscle, number one. Second, inflammation, I mean, it is the base of disease, right? Chronic low-grade inflammation, that's what obesity has. But we cannot start prescribing the medication for inflammation. Fix the body composition first, right? And if the body composition needs help, then you can use GLP-1 to get the patient there, right? But you cannot talk them, yes, I'm going to give you this, you're going to feel better, without talking about muscle, because then you're gonna make the patient worse, accompanying obesity, right? And I think about bariatric surgery, I'm like, we were making patients probably sicker than when they started, right? Because they were losing pounds, 60 pounds in a month. How much muscle do you think? Probably 50% of it, right?
Yeah.
So we're smarter now. We know that this exists. So as a physician who's prescribing a GLP-1, we have to have the responsibility of doing body compositions on the patients, right? And that's the only thing that should make us decide if you're gonna need the medication or not on the patient. But if they need the medication, they need the regular dose. There's no need to start with a microdose if they need the medication. Again, microdosing, or I got to call it underdosing, is more important and helpful in maintenance.
Yeah.
And another thing is, like, people say, well, because I'm not gonna have the side effects. The side effects can be caused by who's giving you the medication. And I think I talk about this, right? That the most important decision after you deciding that, okay, maybe this is a treatment for me, is who you're going to pick for your doctor. And I give you like the green flags, the red flags, what you should be asking, because unfortunately, many doctors and prescribers and med spas are jumping on the business, right? Oh, it's a good business. But they don't have the knowledge, they don't have the training on it, they don't know how these medications work, they don't know how to guide you from day one on what to expect with the medication, right? If you eat something fine, you're gonna have diarrhea. Nobody tells you that, right? And then the patient thinks like they have stomach bug and no.
Or it's the medication itself, when it's really that the medication is being isolated. From the patient.
I really say, and I say this in my book, I think a doctor, to pick a doctor, they should have, and I mean, this is me, but at least 5 years of experience prescribing this medication. Otherwise, they're going with you along the way on learning, right? But I am very conscious that there's very few doctors that will have more than 5 years of experience, or less the doctors that have almost 15 years of experience like I do. And that's what I wrote my book, because it will fill that gap. And it's not like I'm selling my book, because we don't make money in books.
No,
We don't make money on books, honestly. It's because that's what I know and I've learned, and I can give you that as a gift without being my patient. Is even though you don't have an experienced prescriber, but if you're following the book, you're really gonna have the best outcome possible.
but you hit on something really important, Dr. Dumbo, too, which is I personally think, and I'm guessing you feel the same way, the restrictions that we are placing on access based on insurance and BMIs is not scientific, it's not evidence-based. Because people can have a normal BMI
Yeah.
and not have a normal body composition, and they
And
really
the
could
medication.
benefit from these medications. And again, if somebody has the right BMI to get coverage, but has no holistic approach to their care, we're not really doing them a service.
Yeah.
And that's just the reality of insurance, and there are workarounds. But it restricts access, because even with Lilly Direct, it's expensive.
Yeah, but like I think education is really important on patients too, on expenses, right?
Yeah,
How much money have you spent on diets?
Yeah.
Right?
yeah,
On books,
on the meal
on exercise,
delivery,
on
yeah.
exercise programs, on supplements,
Mhm.
on like put together all that
Yeah.
money that you spent that took you nowhere, to be more frustrated than anything, compared to, let's say, 150 that would Wegovy pill, or $2.99 the prescription of it.
Yeah.
Right, so it's also like, and probably that investment is gonna give you the best benefit in health than anything else that you can do and buy. And probably, and most likely, not probably, most likely, you're gonna decrease your list of medications
100%.
in your doctor's office visits with different specialties.
Yeah.
If you, so it's like, we have to be smart where our money is going.
Yeah. Return on investment.
Do you have stuff for clinicians, like is your book tailored?
My book is
to-
made for doctors too.
Okay,
Yeah,
And that's what's very important for me, is to have the language for both. It has all the evidence base for my doctors that wanna know the evidence base, but it has like the language that everybody's going to.
and I mean, even like
understand.
titration protocols.
Yeah.
Super granular in that way, which is kind of awesome. Yeah.
Just for someone online, can you just repeat where they can go for body composition?
So they can go to the InBody website, inbody.com USA or something like that, and then there's a tab that you can put your zip code. And then it tells you around your area who has the machines, right? I mean, in Amazon, you can buy body compositions from $50 to $300, $400, right?
And they all work the same?
I mean, they're not as good as the ones.
I mean, there's not
but
just the
it's
professional
something.
one, but it's better than scale.
Yeah.
Those are better than scale.
Yeah.
I've been on Zepbound for 2 years now. And the last year I've been just hanging out in maintenance 5 and 2.5, but now, the food noise is coming back. I'm starting to gain weight. My in-body, it's the classic C, so I have high visceral fat, 12. Obviously I need to gain muscle, lose fat. What do you suggest?
Build muscle. So
Just build muscle, and do I start going up, titrating back up, or?
depends.
Okay.
If you cannot consume 100 grams of protein by going up on the medication, that's a problem, right? You need to be able to get that amount of protein. And for anybody going on GLP-1, your best chance of not needing the medication long-term or a high dose, or that you're gonna have to keep going up, is your muscle mass. I mean, I cannot emphasize it that much. It's like your muscle is gonna take part of the job, right? So right now, at the beginning, when we're taking you there, probably the effort from the medication is gonna be 70%, 30% yours. But when we're in maintenance, it has to be almost like 50-50, or even 30% the drug, and then your body continues with that 70%. Right, it's like in the background helping you. But it's like if you're hungry, if the food noise is coming, that already tells me that you're not getting 100 grams of protein in your diet. And if you're not getting 100 grams of protein in your diet, you're not gaining muscle. You're probably losing muscle.
I couldn't even walk into a grocery store. I just didn't want to see food. And now I'm like, oh, let's go eat Mexican tonight.
Yeah, because you need the muscle, you need the protein.
Right.
And I think people really, one of the problems with intermittent fasting has been these not eating in the morning, and I think especially for women of my age, like if you don't get that protein in the morning, you're kind of screwed. Like
Well,
then kind of sets the tone.
Then your
That's my
window,
personal experience, and it's what I've seen with my patients too.
then the window of getting 100 grams of protein, it becomes 6 hours.
Yeah,
There's
like,
no
how are you gonna
possible
do
way
that?
you're gonna do
Yeah.
that, right? You need the whole
Yeah.
day from
Yeah.
waking up to going to sleep to be able to get the protein in.
Yeah.
Especially if you're on a GLP-1, you cannot intermittent fasting on a GLP-1.
No.
There's nothing. That's bad for your body.
That's a great question.
One thing, or a couple things really quick, you helped me kind of push myself to this next level of like experience with the GLP by listening to your podcast or your inspirational talks on Instagram. So thank you. It gave me kind of the extra push and courage. And so I just started the window retail about 3 weeks ago. So I lost 3 pounds, which to me that's great, but the organization I'm working with, they said they expected it to be a little bit higher, so they were asking if I wanted to up my dose. So at the same time, I was thinking, should I consider an injection like the Zepbound instead of the pill?
I mean, if you're losing a pound per week on the lowest dose of the pill, why do we want something else? That's perfect. I don't
And that's
want.
what I thought, but when they said that their expectation was a little bit
Who's
higher.
there? Who's there?
We don't.
Oh. I mean, I'm not gonna say that. It's not actually Weight Watchers is doing is they're changing their way that they are. Actually, I like what they're doing. They're building it, right? They're learning. They want to learn. But we don't just go up to the dose just for the pure going up on the dose. There has to be a reason why we have to go up on the dose, right? Because going up on the dose is going to accelerate your weight loss, so you're going to lose muscle, and you're probably going to have more side effects.
Yeah.
Right? Because we need your body to acclimate to a dose before we can start going up, because then we're setting you to failure, right? So you can tell them, no, I'm happy that this is my weight loss. I don't want to lose more muscles, or I want to lose muscle, but we have to educate them too.
Yeah.
Right? So that they don't know.
Do you think just sticking with the pill, since it's very new, because it's still something that the clinicians aren't clear of the success rate?
Well, that's a misconception. We've had with Pill since 2019. It was called Rybelsus. It's the same thing. And it started at 3 milligrams back then. Now this one starts at 1.5, so half. Any GLP-1, the pill, the injection, we have to gradually go up. It should be the same speed, not because one is a pill, one is an injection. And the Wegovy pill is a very, very low dose. So if I wouldn't move you to an injection because it's gonna be like if you're taking 10 milligrams of the Wegovy pill. We don't wanna do that. So what works for you doesn't mean that it works for others. So you don't have to compare what other people are doing and how they're responding. I have 2 sets of identical twins in my practice, completely different response in the medication,
How interesting.
right? So this is what is working for you, and if it's working, why do we need to accelerate it just for the purpose of going up?
And it seems like, Tim, like, are you doing any body composition testing?
Actually, yeah, I invested in human health.
Yeah,
And what you had said, I had a conversation with myself this morning because I gained a pound, but when I checked my body fat, I went down 0.5, which it was hard for me to have that talk with myself to say it's not bad.
Yeah.
And actually believe myself.
yeah,
Because you're so focused on that weight number,
yeah.
you're like, pound,
But that's something, to me, like, how often, what's your like body comp cadence when you're working with someone like this?
First visit in every 8 weeks,
That's really, really important for people to hear.
8 to 10 weeks, yeah, 8 to 10 weeks.
And if you're working with a clinician online, and like, God bless them, right, because there's not enough people like you out there. I think reminding yourself and maybe reminding them
Yeah.
that you would really like to use that as your guide for therapeutic management is really important.
Yeah. And one thing very important for the home composition scales, the level of hydration matters a lot. So I don't know, I've seen some people tell me, oh, in 3 days I lost 5 pounds of muscle, or I gained 6 pounds of muscle in 2 days, right? That's the level of hydration. So to keep the most constant hydration in every time that you measure yourself, the best way is that you wake up in the morning, you pee the night urine, and then you go on the scale. And then every time you're gonna measure, do it the same way, because that's gonna be the most similar level of hydration every time.
That's great advice.
And don't go every day, because you don't expect muscle changes every day. I say every 2 weeks, right?
That's great.
I have a question regarding like the mental aspect. So I similarly, thank you so much. I thought about going on a jail point for like a year and a half before actually, like you said, taking the stigma that it's something to be ashamed of, and have very good success. But then, it's been 6 months and you feel like you start hitting a rut, even with the GLP-1. Do you have any tips for just kind of pushing through, or what to do when you kind of feel like you hit a rut on it?
And what do you mean by a rut?
Maybe losing a little motivation to just continue being as disciplined. I'm actually today I'm lazy and I don't want to go do the weight class. Just a little bit more lax.
Accountability,
Yeah.
right? It's accountability in your doctor's visits. The other day, when I was in Miami last week and I was in the pool, and you learn so much by hearing people's conversations. And they were talking, there was like 3 women talking to each other, and they were saying, oh, this doctor wants to see me every 2 months. Oh, they just want your money. Oh, I want to see every 6 months. That doesn't work like that. We're not magicians, right? We need to see you every 8 weeks for a reason, not because we want your money, because that's how we can see the movement,
Yeah.
right? It's very important for that to keep the motivation going. You need to go to your doctor's appointments.
And to get that feedback too, like.
That's why, that's where you get the feedback, and maybe something can be different, something may be changed, right? So you need to have, at least while you're still in that journey of weight loss, you need that accountability of seeing your doctor and seeing your body composition, and that gets you motivated.
Can you speak to what happens when the GLP-1s don't work? Like there's no change in an A1C or change in body composition, or a doctor says something like estrogen dominance or
That's not a real definition.
you know,
But okay, let's talk about when you don't lose weight. So, and I talk about this in my book. You guys have read my book? I'm gonna be asking questions next time. So many things, right? One, maybe you're not on the right dose, right? Maybe they're not guiding you on the nutrition and the weightlifting, right? they're just giving you the medication and expecting that it does magic on its own, right? So I don't know the story on that, right? Or maybe in the weight and the scale doesn't look like changes, but maybe your internal changes are happening, maybe you're gaining muscle, maybe you're losing fat, right? So many things to consider before we throw the towel and say, no, this doesn't work for me at all, right? So if we checked all of this, and I can have a patient like that, and I talk to them, and when I talk to them, I can truly, I say, okay, walk me through a day of food. What did you eat yesterday? This morning? No. So if I get like into that detective mode and I figure that they're doing everything that really the medication is not working, then I need to do genetic testing, right? Most obesity that we have is epigenetic, meaning it was not just one single gene mutation that caused obesity. I talked about that at the beginning, right? Maybe trauma, environment, industrialization, the food, hormones, aging. Monogenic obesity is a single gene mutation that can be passed through, and that's a very different type of obesity. So if I have a patient that truly, and this is, I can say in my 7 years that I practiced purely obesity medicine, I've had to do it like 5 times. That truly they're not losing weight. It's a swap that you do in your cheek, and that we send to genetics, and then it shows us if you have a gene mutation. Monogenic obesity is very severe usually, and it's diagnosed very early in childhood, right? But there are mild forms that get to adulthood. And because of GLP-1 now, we never had a medication that helped thousands of patients, right? Now we do, and we can see who's filtering there that they're not responding to the weight loss. That's where we need to think about monogenic obesity. Even in adulthood, you could be 60 years old and you can have monogenic obesity. It wasn't so severe that it was not diagnosed, but severe enough that you struggle your whole life. If there is a monogenic mild form of obesity, then it's a different medication.
What about an allergic reaction to the medication? How does that like skin reaction, inflammation?
So the pen, especially the Zepbound and the Mounjaro pen, some patients complain like a little rush around it, right? As long as you're not short of breath, there is not like a generalized, it's more of a localized reaction that you're having to the medication or to the pen or to the metal in the pen, right? Some local reaction. What I tell my patients, if it's really annoying, is take a Zyrtec in the morning, the day off, and the day after your injection, just to avoid that, or maybe do a thin film of steroid before you put the injection, and then give yourself a shot. So there's things that.
Yeah, there's little hacks. And you mentioned something hormonal, and I mean, I don't want to hijack this, but there is a lot of data showing that for the appropriate hormone therapy candidate, the hormone therapy plus a GLP-1 in our perimenopausal and menopausal patients is really powerful. They really synergize, and so I think either oring it is often a mistake. It's not this or that. Like there are things that are changing, and we know that there are metabolic changes that occur specifically in women as we age. So just keeping that in mind, that together they can work beautifully.
Well, that's the holistic part of it.
Yes, right.
And I think hormones play a really important role in sleep.
I was just.
I cannot gonna, my
Yes.
patient, if she's not sleeping, she's not gonna want to go to the gym, she's not gonna.
Yeah.
She's gonna be tired, cranky, right? So I think it's more of an indirect effect that makes it the environment better
Yeah.
and more receptive
Yeah.
than necessarily an interaction between estrogen and GLP-1.
Quick question. So in terms of side effects, I have family members on medication and, their doctors actually told them like, you want to drink a lot of water and you want to have the appropriate amount of fiber and all that stuff. And they're doing all that and still having problems in this particular case with extreme, oh my gosh, what is it called?
Nausea?
Constipation, thank you very much. Postmenopausal brain. What are there upcoming meds that deal more with okay.
So the nobody has to suck it out for the benefit of the medication,
Right.
number one, right? If the side effects are there and they're not improving, they need to decrease the dose.
Okay,
They need to take a step back
Yeah.
and be in that lower dose where they tolerate it better and then go up,
okay.
right? Constipation can be multifactorial. I don't see constipation as much with tirzepatide, which is Mounjaro and Zepbound. Definitely constipation with semaglutide, which is Wegovy and Ozempic. I would say I tell my patients back then when it was more Ozempic and Wegovy, Miralax at bedtime, I would give kids. Magnesium citrate also helps with constipation.
Right.
Hydration, movement, right? And that's the reason that, and not because I want to throw my protein there, but I develop my protein because I added fiber to help, right? So you can do supplement of fiber, right? But with tirzepatide, I don't see it as much. Actually, patients that had constipation say that now that they're less constipated. But I think it's not a problem necessarily per the medication itself.
Right. Thank you so much.
I'd like to get your opinion on if not all physicians have, accepted that, or at least have the reaction that obesity is a disease, and so have said, that a patient is not a candidate for this medication. How do you feel about, these weight loss programs that do prescribe the medication, or what sort of recommendation would you have in terms of like an alternative?
The telehealth in my book.
Okay.
So my book is going to help you more than many doctors in person will help you because this is experience that I've gotten 16 years of prescribing. I always say, I know this medication is longer than my kids. The book is really your best companion with any doctor. That's not right. In telehealth, I mean, again, they're very helpful and they will get the prescription, but don't do it without the book.
Yeah.
It's super practical.
I had my doctor order it.
Oh, really?
Oh, that's
She
great.
got on Amazon and put it right there.
That's amazing. I see there's somebody with that.
It's kind of a stupid question, but how do you actually burn fat? Is it through breathing?
Through what?
Breathing?
No. We will never have a problem of obesity through breathing. It's caloric restriction, right? You need to eat less calories than what you burn. So with the medication, with the GLP-1, you eat less, you eat
And how it
maybe.
just melts?
No, you use it for energy. It burns for energy. It gives us the energy that we need. But if the energy is in the calories that we're taking, the fat takes a step back and say, well, I don't have to do anything. But by caloric restriction, and this is very basic, right? By eating less calories, you burn more fat for energy.
How? They just come off? It's
Well-
not breathing, the energy, walking or
It metabolizes. It starts to break down to give us the energy that we need.
The body uses it as a fuel source, so there's
Like
cellular reactions that occur. And instead of the calories, because every single thing your body is doing, talking, thinking, but mostly moving in the muscles consume the most calories, which is why Dr. Salas-Whalen has talked so much about using and building muscle. There's a metabolic process, a chemical process in the body that takes any fuel it can. So the easiest is whatever you bring in, but if you don't bring in as much, it's going to use the sources inside, and then through metabolic processes and then waste product. I think you're asking sort of that, like it is lost through waste products in your body. Yeah.
Oh, yeah. Do you talk about for postpartum? Do you have any patients that come to you postpartum that I'm sure this isn't you can't take it right while you're breastfeeding this GLP? Oh, really? Can we talk about that?
There's small data, small papers, right, that had showed that the molecule of the GLP-1, and this is injectable. I'll talk about the oral. The injectable, the molecule is too large to go through the mammary ducts where the milk goes through, right? Number one. Second, if the baby ingests the GLP-1 that is injectable, their stomach acid breaks it down. There's no effect. Right? We're bypassing the oral route with the injectable because the acids, right? So even if the baby, I've had patients that because the obesity was so severe and they causing a lot of distress, and I in touch with the pediatrician, and just to make sure that the weight of the baby is good, but again, it's very unlikely that it's going to pass. Now, oral GLP-1 may be different, right? Because it's designed to be not broken by the stomach acids, that's why we give it oral. So if the baby does pass it through the milk, then the baby can have some effect of the GLP-1.
And actually, this is a good, GLP-1s are produced in our, we make
We make
GLP-1.
it, it's a hormone.
It is a
Not a
hormone in our
peptide, it's a
body,
hormone.
but it lasts for a very short period of time in the body.
It's
Right, so when we're doing these therapeutic doses and formats, we're just getting a longer lasting
Well,
impact.
what we, the ones that we know, they're engineered
Right,
to be long lasting,
exactly.
to have a half-life of 7 days, as an
Right.
example, right?
Right, so this is not like, this is really unique in that way that it is something that physiologically we make, but we're just extending the life of it.
It was made better, exactly.
What do you recommend for calorie restriction, like 500 calories in a day or more?
Depends on the patient, depends on their,
Or deficiency, I mean, sorry.
I don't want any patient to count calories.
Love that.
Zero counting
Love
calories.
No
The only
counting calories.
thing that I need to count is your grams of protein, that's it, that's all I need to count. Because if you're consuming 100 grams of protein, I know how many calories you're gonna be eating, right? But it's gonna be low or gonna be healthy calories. And the medication is taking care of that. I don't need, I like to facilitate as much the things for my patients and not make it complicated. In counting calories, the only time that I ask patients to count calories is when they're eating the protein and the fat keeps going up, right? Then maybe there's a mismatch there. So
Right.
that's the only place that I say, okay, maybe let's see how many calories you're eating. And
Yeah.
because of eating 100 grams of protein, they're maybe eating 2,000 calories, right? So that's why the importance of lean animal protein that is going to be grilled, baked, broiled, poached, right? Then like bacon and
Right,
like
I mean,
it's not
you
Atkins,
could
you
do
don't want
100
Atkins.
grams of protein of bacon, but I mean, that probably wouldn't work.
Yeah.
Yeah, we're gonna take one last question. Yeah,
Okay, yeah, what happens with age, if you're over 65 and you have mobility issues? And how is that the GLP work with older ones? And maybe they're doing protein, they're doing all this right stuff, but they don't have the mobility, and so how does that work?
So the GLP-1 is hopefully improve your mobility, right? Number one. I have patients as old as 79 on the GLP-1. As long as you're consuming the protein, you're losing gradually, right? A half a pound to max a pound per week, and you're not losing the muscle. You can do the nutrition, and then eventually, as you're losing body fat and body weight, you become more mobile.
And to add to that, what about like the weight, you're supposed to work out the weights, you're supposed to do heavy lifting and all that kind of stuff. What happens if the person is older like that? You know
So
what I mean?
it's never too late to start lifting weights, number one. Never, only death is late enough. But at the bare minimum, and I have this a lot, not just in old patients, I have this in young patients when they weigh 350 pounds, right? 300 pounds, that going to the gym is not only physically limiting, but intimidating and emotional and brings trauma. Sometimes it takes about 20 to 30 pounds of weight loss before the patient starts to feel like to exercise. So it's not a prerequisite, right? At the bare minimum, what I need my patients to do, even if they cannot move, is the protein, to not lose the muscle. To not lose the muscle, I would say is 80% the protein that you take in your diet. To build the muscle, then we would talk about the weightlifting, right? But there's no excuse to because I cannot lift weights, I cannot use a GLP-1. Yes, you control the protein that you eat, and you use the medication, and then eventually you will start wanting to be more active.
Thank you for this amazing book. Thank you guys for all signing on. Thank you all for showing up. We're gonna figure out how we're gonna get you to sign this book.